welcome to the final side event of the pre-conference day. We have been through already 3 side events. We started in the morning with a side event around type 1 diabetes in humanitarian settings. We went on with the side event around epidemiology and the Diamond 2A collaboration. Just before the coffee break, we had a session around this new global initiative. So I believe it's fair to say that the first 3 side events have represented 3 different but all very important angles of our conference, our event, and the framing around advancing a global roadmap for improved and integrated care in low-resource settings. We have been working on the preparation of this conference for a while in the organizing committee. And as you could see from the preparatory material that was circulated and was part of also our invitation letter, the concept note, and the annex to the concept note, which was and is the short introduction, you can say, to the Lancet Diabetes and Endocrinology Commission on Type 1 Diabetes, which I believe was formally launched in November 2023, so not that long ago. And that is to say that our final side event of today is organized by the Lancet Diabetes and Endocrinology Commission on Type 1 Diabetes. And it is entitled A Comprehensive and Pragmatic Global Plan to Improve the Quality of Life and Care of People with Type 1 Diabetes. And I think it's a very important section of our pre-conference day leading up to the main conference day, which will start tomorrow morning. And we are very pleased to have many of the commissioners here with us, and without further details, I would hand over the microphone and the stage to one of the commissioners, David Barron, please.
Thank you, Ben, for the introduction, and thank you, all of you, for still being here after a long day. So, as Ben mentioned, the Lancet Commission really focuses and is aligned in its focus with this meeting, and we felt it was important as a commission to participate, share with you our initial ideas as we shape the way forward with this commission. And I'd like to acknowledge the support we've received from Breakthrough T1D and the World Diabetes Foundation for the work of the commission that's coordinated at the University of Geneva and the NCD Policy Lab at the University of Geneva. So why a Lancet Diabetes and Endocrinology Commission on Type 1 Diabetes? We were approached by Marta Koch from the Lancet Diabetes and Endocrinology around the centenary of insulin and its first use, saying, should we be doing something around type 1 diabetes and access to insulin? We also saw, and for those of you who participated and heard Professor Tuomelito and Professor Green in the around 2022, 2023, there were more studies around the epidemiology of type 1 diabetes. There was a paper by Professor Green, Gregory et al., Ward et al., the launch of the Type 1 Diabetes Index by Breakthrough T1D. So there was renewed interest. And that highlighted that, again, we can argue and discuss the numbers, but 9 million people worldwide have type 1 diabetes. But that we face global inequities and national inequities. So we have low and middle income countries versus high income countries. The differences are stark in terms of access to insulin, access to technologies, but also in high income countries, more and more vulnerable groups being exposed to similar situations to their peers in low-income countries. But we've also seen success, and I think this conference has highlighted and will highlight over the next 2 days the success we've had in type 1 diabetes and how can we build on that success and the rich history of type 1 diabetes management. Yes, we've had 100 years of insulin, but we've also had 100 years of managing type 1 diabetes, and how can we learn from these? That said, and these are papers that some colleagues in the room have written and many of you are familiar with, we still face these significant challenges. So here are the 6 lead commissioners. So you'll hear from many of us during this session, as well as other colleagues. And as I mentioned, in 2023, we launched this Lancet Commission. And we've now invited, and we're in the process of finalizing a list of 25 other colleagues who have been invited and who are at different stages of accepting to join this adventure. And some of you in this room are part of that adventure. So what we felt was important, and it's important to highlight these in front of this audience, is our guiding principles. And we won't be providing any therapeutic recommendations. So any of you who are expecting new guidelines on the management of type 1 diabetes or recommendations, that is not our aim. That we aim to have wide representation. So Jessica, who will be presenting soon, will highlight what we mean by wide representation. That we want to engage, and this part of the engagement is already this evening, engaging with you and engaging over the next 2 days, hearing about your experiences, seeing how we can keep that engagement going. And of course, because this commission will be published in a Lancet journal, aiming for scientific excellence and innovation. And then finally, and I think this has come up in terms of, I've been involved with the early career research track that's been running in parallel, is this element of practical solutions. We have a lot of research, we have a lot of knowledge, but how do we translate that into practical solutions that impact the daily lives of people with type 1 diabetes? And then also is, how is this commission part of a wider type 1 diabetes environment? We have this meeting, which is unique. I've been working in type 1 diabetes and diabetes for a long time. It's the first time we have a true meeting dedicated to type 1 diabetes, bringing together practitioners, funders, the private sector, policymakers, clinicians, people with lived experience, all together with a common goal. We, of course, all of this is framed within the Global Diabetes Compact. We have ongoing projects on access to insulin, access to self-monitoring. We have donation programs that many of you are familiar with. We have discussions around epidemiology and data. There's many NGOs present in this room who run fantastic projects. We have research. We have early career researchers, young researchers doing amazing research in their countries and globally. Advocacy, and a whole wide range of things. And again, funders we need to recognize, such as the Helmsley Charitable Trust, the World Diabetes Foundation, or Breakthrough T1D. And so how does the commission get framed within this wide environment that, of course, will keep moving forward? But again, how do we keep engaged with you? How do you keep engaged with us to make sure that when we come out with this commission, that we highlight the amazing work that is going on in the area of type 1 diabetes? So I will soon hand over to Marta, who's the editor-in-chief of Lancet Diabetes and Endocrinology, but this is the agenda for this event. So Marta will highlight what is the Lancet Commission and what does it aim to do. Then we'll have Jessica, who will present very briefly what we're thinking about, what our conceptual framework is, what our work plan is. Then Kaushik Ramaya, who many of you know and who's also a commissioner, will moderate a discussion and Q&A. And here we're looking for your comments and, in a sense, your live peer review of our initial thoughts. And then Sana Ajmal from Pakistan will moderate a panel discussion. And we're grateful that Karine de Beaufort, one of the other Lancet commissioners, as well as Mats from the World Diabetes Foundation, Stephanie from Breakthrough T1D, Molly from Health Action International, and Nupur from Blue Circle can contribute their thoughts around this commission. And then finally, we'll hand over to Kaushik for some closing remarks. But again, thank you for being here. Thank you to all the participants. And again, well, thank you to Marta for being here and her trust in all of us as commissioners to hopefully deliver very soon an excellent commission that hopefully will build off this meeting and the discussions we're having over the next few days really deliver something practical that we hope will fundamentally change the outlooks for people with type 1 diabetes globally. So thank you, and Marta, the floor is yours.
Thanks so much, David. Thanks, Ben, and thanks everyone for being here. I really enjoyed type 1 diabetes conferences. I always find the community very welcoming. And I'm really happy to tell you a little bit more about what is a Lancet Commission. I'll keep this short and simple, and I think many of these messages will not come across as any surprise to you, but they do come across as a surprise to many other communities. I think the type 1 diabetes community is very collaborative, and there is that spirit of collaboration and the power of that collaboration, which is so important. So the Lancet, as you all know, hopefully, is a medical journal. It was launched more than 200 years ago by an English surgeon called Thomas Wackley, and his interests went way beyond medicine. He really campaigned against incompetence and nepotism. So one would like to think what he would say about today's chaotic world. Now, in 1823, the Lancet was there to inform and reform, but also to entertain. And the Lancet nowadays is far more than that. But it is really campaigning for health equity and justice, knowledge for better health outcomes, and uses research as a tool for accountability. And I think accountability is a word that we have heard many times today. And I think more important now than ever, there is the understanding that health is cultural and highly political, and we should never forget that. So Lancet commissions are scientific reviews, inquiries, a response to an urgent and often neglected or understudied health issue. They are science-led, as David mentioned. And the power of a Lancet Commission is really the fact that they are very international and multidisciplinary collaborations that aim for transformational change, which, again, now more than ever, has to be focused on policy and political action. And this is with the understanding that organized science can really provide a strong platform for advocacy. And the role of the Lancet here really is to convene experts in different health areas to promote change. So what makes a great, hopefully successful Lancet Commission? So the first thing, of course, is it must be innovative and groundbreaking, and I think the things that David has presented really do fall into this category. It should be, it's not a report, it's not a review, it's so much more than that, because again, you focus on political action. So do think big, and while doing that, bring together people who are collaborative, who are passionate about the topic and about collaboration, and who are committed, because this kind of work really do require a lot of time and effort, energy and commitment. I think it goes without saying nowadays that it's important that authorship is balanced in terms of geography and gender, and that includes researchers from different seniority levels and different disciplines. Again, the power of that multidisciplinary collaboration. And from different school of thoughts, because, you know, these topics can be quite controversial and people do have different opinions. And can we have those difficult conversations, bringing people together with different opinions, but working towards a common goal? And think of a bold message, something when we give this talk, not only me, but many of my colleagues, when we talk about Lancet commissions, we think of a bold message. What is really the take-home message you'd like to convey in this work? We live in a world where there's so many news and people are overwhelmed by news, and it's hard to have the time and the energy to catch up with everything out there. So what is that bold take-home message of your work? And we also say, visualize the front cover of a Lancet Commission. with a compelling quote that captures the core message. And here are just two examples of two commissions we published. One is the Lancet Global Health, and this one here on the right side is definitions and diagnostic criteria on clinical obesity that we published about 2 weeks ago to Lancet Diabetes Endocrinology. And what's the story? Think of a compelling story, a compelling narrative that has strong arguments and recommendations. Again, as David said, is not only about the scientific understanding of a field, but is about action and recommendations. And while you're thinking of that story, be critical about the field. Think about what's not working in this field. What are the current knowledge gaps? Where are the limitations? What are the barriers? But also, what's not being said? What's the elephant in the room? We talked today about the need for flexible health systems and resilient health systems, but someone mentioned about corruption. These are issues that we have to challenge. Can we challenge people who are in the power? Can we challenge the commercial determinants of health? These are all important and very difficult conversations to have. And, you know, obviously it has to be original. Again, so much is being published in the field of NCDs in so many areas of health, all these competing priorities. Successful Lancet commissions do propose compelling findings that do move the knowledge and the field forward. Just an example of the Lancet commission we published 2 weeks ago on obesity, the authors proposed a completely different way of assessing obesity and diagnosing obesity, and made a distinction between preclinical obesity and clinical obesity, which was quite a paradigm shifting. But, you know, novel findings aren't really that important if they don't come together with recommendations. So what are the actionable points? Thinking also that, again, fewer and focus recommendations are much more effective than having too many. And targeting the key stakeholders, but also setting timelines. And how do we facilitate follow-up? How do we measure progress? And, well, I think nowadays everyone who reads the news thinks this is all doom and gloom. So can we be still inspiring and optimistic? Can we focus on the potential impact that we can achieve if the recommendations are implemented? What key benefits are there and how to measure them? And who's the target audience? If we're talking about change, who needs to be involved? Who needs to be involved for action really to happen? When we talk about commission, we are thinking so much broader than just the authors, just the commissioners, but we're thinking about external consultations with different groups that perhaps not being represented by commissioners. Societies, you know, obviously it goes without saying in this specific room, you know, NGOs and patients and people with lived experiences, advocacy. It's all really important to consider. Now, just a couple of words about the involvement of the Lancet in these commissions when it comes to preparing for the launch. So, again, just giving an example of the obesity commission we published, there was a lot of effort from the Lancet in preparing for the launch in terms of press releases and press briefings. And it's really preparing the press to receive what it is a big commission and leveraging the momentum. So when we had the launch, so on the left side is our launch in London, these different commissions that we have launched in past years, but this launch was happening in London live, but it was followed by different launches in different countries at the same time to really try to leverage that momentum. And in terms of press, there was a lot of effort into preparing for this launch, as I mentioned, which has resulted in 1,700 articles that covered the commission. Now, of course, as you all know, obesity is a very controversial topic, and everyone has a say on it, which maybe a reason why it was so well covered. But I think we can do the same with type 1 diabetes. We can get this amount of coverage. Now, not all guidelines are good, and not everyone gets it, especially when it comes to very controversial topics. So we did have to reach out to some of the UK tabloids and ask them to kindly rephrase some of the headlines. But again, it comes to show how controversial some of these topics really are. And I'll just, end by saying that the publication of a report like this really is the beginning. Once it gets published, you will receive a lot of feedback, and it's great that we are already having this conversation here and gathering feedback. But once it's published, there will be even more feedback. And how does one deal with that feedback? How do you deal with criticisms? How can you implement all these recommendations and really promote action and change? And how do you monitor and follow up? Indeed, it is just the start, the publication, and hopefully once it's published, there will be lots of good reasons to revisit it and monitor and follow up to ensure that change really does happen. And I think that's it for me. Thank you so much, David, for inviting me again. Thank you so much for your time.
Thank you very much, Marta, and hopefully we will be able to get 1,700 articles on type 1 diabetes, but no promises. So now I'll hand over the floor to one of my colleagues and co-commissioners, Jessica, who will walk you through, in a sense, our very initial thinking. And as I said, the aim is really in the session to follow what Jessica will present, that will be moderated by Kaushik, to really get your live peer review and really use this as an example to shape what we're thinking about as we move forward. So thank you, Jessica.
Thank you, David. Okay. Okay. So, hi everyone. As David mentioned, my name is Jessica Safra. I'm part of the core commissioners, and I'm going to be presenting our work plan, so some of the activities that we will be conducting for the Lancet Commission, and also a first draft of our framework. And again, this is open for feedback. So first of all, the goal of this Lancet Commission is to develop a comprehensive, pragmatic global plan, and the aim is to improve the quality of life and care for people living with type 1 diabetes. And we want to consider two main things. The first one is that we want to consider the life course, so a person who is living with type 1 diabetes, but throughout the life course. And then we want to consider the context where they live in, meaning that we're not going to focus on recommendations, for example, only for low-middle income countries or only for high-income countries. We want to provide recommendations that will be flexible and that will consider all of the context. And I don't think I have to justify why we are working on type 1 diabetes here, but it is good to mention that this is a good tracer condition in the sense that the outcomes that we get on type 1 diabetes reflect how the healthcare system is working. So that's why it is important to work on this condition. And also some of the recommendations that we can provide can be potentially translated to other NCDs. And the other thing that we need to keep in mind is that this is the amount of hours in a year, and this is like an estimation of how much time a person will spend managing the condition like on a day-to-day basis versus the time that they will actually spend in contact with the healthcare facilities. Just to say that this is a chronic disease and the person will have to spend a lot of time managing it, so we want to shift the focus to the individual. Okay, so how do we want to achieve this goal? We have different activities. The first one is to document past successes. So we want to know what has already worked so we can use that. We also want to use current knowledge, and this is regarding different areas. I'm going to talk about the different experts that we are going to involve, but the idea is that we're focusing not only on what we know like from the medical, epidemiological field, but just involving different people with different backgrounds. We also want to, like, once we have identified all of this, we have identified also some gaps that we want to fill conducting new research. And finally, we want to involve different groups of stakeholders, including people living with type 1 diabetes. And hopefully by doing this, we can get to identify and prioritize the different challenges so that we can propose and promote the recommendations. So I'm going to walk you through some of the activities that we are conducting, and I have separated them in 3 or 4 categories. So the first one is just to get an overview of type 1 diabetes healthcare systems. And in order to do this, we are conducting narrative and systematic reviews. And one of them involves identifying gaps within the healthcare system. So for example, how is the healthcare system working right now and what could we improve? And then another review that we want to develop, what that is in the process, is to develop a scorecard to assess quality of care. This is in relation to, okay, we have identified some gaps in the healthcare system, so we have more or less an idea of what we would like the healthcare system to do. And the idea of the scorecard is to have a tool that is easy to use, that can reflect on the healthcare system functioning, and that can also help benchmark the different healthcare systems and also assess like if there is progress or not, monitoring, basically. And another narrative review that we want to conduct is related to mapping the different stakeholders, which David already mentioned. There's not only the clinicians, researchers, and so there are NGOs and other actors, so we want to map them to get a better understanding of what they are working on, what are the gaps, and then how can we work with them. So that's just the healthcare system in general. We also want to get in-depth understanding of some specific topics. And in order to do this, we again are going to conduct some narrative reviews and systematic reviews. And one of the topics that we are going to work on is, for example, gender perspectives. And this is not only, is there a difference between like epidemiological aspects like incidence, for example, in boys and girls, but rather considering how gender and gender roles can shape the management, for example, of a condition. Then we also want to consider adult and geriatric care in type 1 diabetes. As it has been mentioned, like, since the discovery of insulin, people are living longer and longer. This is going to keep improving, and it's also going to be different in, for example, low and middle income countries. And so we want to prepare for what is going to come. So we are also conducting a review on this topic just to get a better knowledge, to be able to provide some recommendations around that. And we are also considering the psychosocial impact of type 1 diabetes. So that will be another of the reviews that we are going to conduct, because we consider that these 3 areas have been, like, they are important, and there are studies on them, but we need to go deeper. And also, we have identified some gaps, and for this, we are conducting some original research. And these are only some examples. So one of them is using geomapping to optimize accessibility to care, meaning that, or acknowledging that it is not only having insulin in the healthcare facilities, for example, we also need to ensure that they are placed in a way that the people can actually access to them. So basically geographical access. And the idea of this study is to find the best way to place the services so that people can access to them, and that it's also like an efficient use of resources for the healthcare system. And then another exercise that we are conducting is this modeling of investment. The name is quite long, I cannot pronounce it, but the idea is that after we have insulin for everyone, then what are the next steps that need to be implemented? So for example, we have insulin, and then do we need to improve the education of the patients, or do we need to have transition clinics or so? So we're looking into different types of interventions, and the idea is to assess in which order they should be implemented to provide recommendations for governments. And then another one is assessing the quality of care of type 1 diabetes using secondary data. So this has been mentioned in the previous session, like we need data to know what outcomes we're getting. So one of the activities will be related to this. And yeah, so David mentioned we are 6 core commissioners, but we're not going to do that alone. So we are working with some other commissioners that have been invited. So far, we've had 24 to 25 positive answers, and this is just so you can see the distribution, like the geographical distribution of the commissioners. We are also aiming for gender balance, and also we want to have people with lived experience within the commissioners. Yeah, I don't think I need to say it, but we cannot provide recommendations without involving people living with this. So, yeah. Yeah. And we also are proposing to have some expert engagements. So not only the core commissioners and the 24 commissioners that I've mentioned are going to work on these recommendations, bringing their different backgrounds, we are also going to propose to have some other activities, such as workshops or presentations. And the idea of these activities, and this is one of them, is to learn from each other and to foster discussions around this topic and around the Commission, and also to develop connections. Yeah. And yeah, the idea here is those are the activities, and we are working around this framework. This is a draft. And again, the idea is to present it so that we can maybe get some feedback. So what we have here is a person living with type 1 diabetes. We wanted to put this person in the center of all our work. And again, we were, as I mentioned in the goal, we have life stages within our goal. The idea is that this person living with diabetes will go through different life stages. And here I'm showing a man, but it's also for women, and acknowledging that for women it may be different. But the idea is that there are these changes that will go in the life of the person, and we need to consider that. And we have around diabetes, which is also dynamic, so we need to consider that. And we discuss a lot about the healthcare system, but we need to consider that, again, this person is going to be managing the condition on a day-to-day basis. So there are some aspects, like social aspects, that are quite relevant. And for example, if we look closer to the individual, we will have the interaction with the caregivers, family members, whatever happens at the home environment, work, school. And then if we look at it with a little more, like from a broader perspective, we can have the societal environment, which can have different policies, and then the consideration of vulnerable populations, the economic impact, and also gender roles. So we're considering all of these around the individual. And of course, this individual will interact with the healthcare system. So we have the healthcare system, and we have, for example, the services that the healthcare system needs to provide. So again, it's not only here is your medicine, but really providing early diagnosis, education, and, for example, screening complications and so. And we also want to take into consideration some other aspects. So yes, the services, yes, the insulin, but then also the human resources, how they are trained, financing, how it is financed, what is being financed, and then the data environment, again, so that we can collect data to improve the care. And that's okay. that's what I had prepared.
So, good evening, everyone. And I think you've heard the introduction. You've heard the concept from the Lancet. Martha, you heard what basically the Lancet Commission means, and you heard from Jessica the conceptual framework. So, we would like to now keep the floor open for any questions, any inputs, any suggestions, any recommendations. So the floor is open. We'll have next 10 to 15 minutes of question, answer, and discussions or any inputs. So, welcome. I'm sure you had a good tea and coffee, nice sugar-free cakes, and salted peanuts. So, you should be up and about and up, ready to ask questions. Yes, please. There's a mic coming there. Yeah. We are open to questions, any suggestions, any recommendations. Yeah.
Zoran from Union of Association of People with Diabetes of North Macedonia. Maybe you have covered that from the beginning. I was out. I came towards the end of presentation, but seems that the concept is really, really great. I'm just curious. Really, I would appreciate if countries like North Macedonia or Balkan or Southeastern Europe would participate. I just want to know, are they included, or what is possibility for participation? Because really I like, considering that I'm a lot of with methodologies in development, I I really like the process and what I have seen here.
Yeah, so basically you're asking whether there's a representation from the Eastern Europe and those countries. Yes, thank you. Thank you for that suggestion. I'm sure it has been on the radar, but we'll take into consideration that. Yes, please. Yes.
Yes, Graham Ogle from Life for a Child in Sydney. Kaushik, I'd be interested, or David, geomapping was mentioned, and I just wondered what you were thinking about that and what your plans are there.
So I think within geomapping, the idea was that identify within a country or look at some of the countries and see where the access to type 1 diabetes services are, and whether there is a gap in certain areas, whether it is urban, rural, or it is a different country. So basically looking at that conceptualization and trying to see whether we can do something to improve the care and the services, because one of the challenges in low and middle income countries has been people to access care. And when the distances are long, then you find that these people normally don't attend the clinic. So that has been one of the major components. Yeah, so David, you want to, yeah.
Thanks for that question, Graham. So for those of you who are not familiar, geomapping has been used for a whole variety of health-related issues, most commonly for maternal and child health, for emergency obstetric care. And so in speaking to experts in this area, what we did was we put them to the challenge to say, for type 1 diabetes, again, we don't have data, but we're assuming that in a country like Australia, they're dispatched throughout the population equally. We can't have a pediatric endocrinologist or a diabetologist in every single village or town or area. So the idea is based on where facilities are, the geography, how do we really need to rethink how we deliver potentially diabetes care in some countries. So we've started now with getting data from Ghana and Peru to see what would that look like in two very different countries. Again, urban, rural split, geography, how does geography play into it? So Peru, 3 distinct geographical areas, the coast, the mountains, and the Amazon. And so the idea then is to see what other countries can we get the data both in terms of some data on type 1 diabetes as well as data in terms of facilities, roads, to use this as another tool to help us rethink how we deliver services. As Jessica mentioned, not only the insulin, but do we need, insulin in villages, whereas HbA1c might need to be in sort of regional capitals, and then type 1 diabetes care in large cities, but that's the idea. So I hope I answer your question. While I'm speaking, just to come back to your point, I think this element of participation and engagement is something that we're keen to do. And I think we as commissioners, we really want to see how we engage different people in different ways. So clearly we can't have everybody be a commissioner, because then it just becomes unmanageable if we have hundreds of people writing an article, but we want to get input throughout the process. So for anyone who's interested, we'll see how we can keep you informed. Again, today is the first time, although we did launch in November 2023, we haven't had the chance to really come together. So we really want to keep engaging. So please feel free to reach out.
Yeah. Yes, Dr.
Thank you. My name is Omar Buguyu. I'm an assistant director for NCD, mental health and substance abuse from the Ministry of Health in Tanzania. My concern, especially to the Commission, is I wonder on the spectrum of the commissioners in this group, because type 1 diabetes, especially juvenile, is not just an endocrinological issue. There's a lot of developmental issues to most of these adolescents. Looking at the needs, especially on educational issues, so I would probably think that we need somebody on that aspect as well. And there's a lot of behavioral issues. Taking an adolescent is in a lot of transitions in schools, puberty. There are a lot of needs, especially on sexuality, and a lot more that they need. So we need at least a psychologist in the group who can comprehend and understand the needs, psychological, physical, and other needs within the consortium. So could probably think of having a wider spectrum beyond endocrinologists, because this is developmental issues, especially in the juveniles.
Yeah, it's a very valid suggestion. And in fact, the mapping has been done. And as Jessica mentioned, in the additional group which we are looking at, we are looking those subject experts. So it's already it's a work in progress. Yes, please.
Thank you. I'm Erica from the Swiss government. A lot of Lancet commissions, they come up with very good recommendations. I'm thinking about, for example, the recommendations on digitalization or different, on determinants, on climate change, and etc. And then, so the recommendations are very good. Evidence which is produced is very good, but then they are not taken up by, those who implement or influence the resolutions and guidance and etc. And so, what have you thought about this, and how to integrate these kind of considerations right from the beginning? I mean, when it comes to, I'm referring here to the Lancet Commission on Digitalization, the GH, what was the name? Governing Health Futures, I think. The Commission on Digitalization, which was led by Lona Kickbush, many years ago. And we were involved as donors in contributing to finding, ways and schemes and funding schemes and, ways of taking up the recommendations and integrate them into programming and bring this evidence, on board when we negotiate resolutions and other normative work in UN, including in UN fora. So have you thought about this? I mean, how to implement, once you have published your commission, what will you do? I mean, what will you do to foster this kind of commitment from the international cooperation and global health community? Thank you.
Yeah, I think you are raising a very important point, and this was one of the first subject matter which we discussed when we had the first meeting, that are we really producing a Lancet Commission for publications, or we are presenting a Lancet Commission which is going to be implementable. And I think that's the reason why our approach has been different, to make sure that we have all the stakeholders on board. And most important is some of the recommendations which come in has to be involved with the policymakers. You need to get the advocacy done right so that you can change the policy to bring about the change. So that has basically been our first criteria of whatever we do, although there is science, but it should be an implementation science which is going to benefit what we want to do. So that has definitely been taken into consideration, because we looked at previous Lancet Commission reports, of which have just lied on the desk. Nothing has been done, published, but no action taken. So that has been taken care of. Yeah. Rest assured about that. Yeah.
Thank you to the presenters. My name is Gladwell Gadesha from the Ministry of Health in Kenya. So I'm interested in the so-called societal perspective that was presented. And I know the issue of policy environment was brought out, but not very clearly. I think from the ministry point of view, we'd also like to see the influence or impact of the broader policies we are making, the prioritization of type 1 or lack of prioritization, the integration into other UHC policies. Are these making a difference in the final impact of the care we offer, and also the partnerships that are existing, the fashion and the manner? I think the Lancet Commission would also take a deep dive into this and correlate it with the care of type 1 diabetes. Thank you.
Yeah. Yes, Dr. Gladwell, I think 3 issues here. One is whether type 1 diabetes should be integrated within the normal services, and especially where insulin is essential for life. So whether the governments and the policymakers will make sure that access is important, whether the donor funding is there or not. 2 is whether to make sure that it is integrated within the other, because it's not a vertical program. It should be an integrated program within different levels of care with a referral pathway, whereby the diagnosis, the management, and the complications are managed at different levels. So that is also being taken into care. And who are the other stakeholders who are actually assisting to improve the care? So all those 3 components will be taken care of.
Thank you. So I have questions to you. What would be your source of data at the validation process? Source of the data and the validation process.
David, you would like to answer that?
I think as Jessica presented, there are multiple studies that we're going to do. Some of them are reviews, some of them are narrative reviews, some of them are systematic reviews, and then some of them are original research. And I think those different approaches call for different validation. For example, coming back to the investment case, so we've done a systematic review that's just been completed. We've had a first round of a Delphi survey, and some of you may have received that questionnaire and responded, so thank you. And so there's that external validation of a systematic review, and we're now analyzing that initial review of these experts to then define the next stage. So I think your question varies from piece of research to piece of research. In terms of putting this all together, I think the validation is, you could argue, the diverse group that we've assembled, both in terms of geography, in terms of skills. The comment about endocrinologist, I'm not an endocrinologist, I'm not a clinician. We have a variety of skills on the commission. And again, this focus, as Jessica mentioned, on people with lived experience. And again, for us, that's part of this validation process. It's not just what do we as academic scientists, clinicians, researchers think, but also what is then going to be useful for the type 1 diabetes community in terms of moving it forward, and coming back to the point that Erica mentioned in terms of moving this forward in different ways. Practical solutions on the ground for diabetes clinics, messages for advocates, possible paths for funding, for research funding, for implementation funding, and then hopefully also to change the policy environment.
Thank you. Yeah.
Hi, thank you so much for presenting this. James from Helmsley Trust. I wanted to understand it's a lot, everything included in that conceptual framework. So I'm curious to better understand the geographic scope of this. Are there specific countries that you're going deeper on to find those best practices? My second question is a little bit about how you're incorporating findings from previous Lancet commissions. Erica mentioned the one about digital health, so there's like content-specific work. I think, as you know, Helmsley has funded the NCDI Poverty Lancet Commission, which did quite a bit of work on that service delivery package and referral network and things like that. We have a commissioner in the room with us. So wanted to hear how that touches on existing type 1 diabetes research, but also some of those health system levers that are going to be incorporated. Thank you.
Yeah. So I'll respond to the different reference to the different Lancet commissions. And regarding the representation of the countries, David will respond to that one. We are actually looking through all the different Lancet reports which are related to this disease, and we'll definitely look at what has been recommended, what has been achieved, what has not been achieved, and we'll be looking, because there was Lancet Commission on Diabetes in Sub-Saharan Africa, there was this Poverty Commission report, and there have been several other reports which are interrelated regarding the primary health care, then there's digital health and all these things. So we are definitely going to look at them, review them, and look at what is plausible, what is not plausible, and then to take that into our learnings. David, you want to?
Thank you for your question, James. I think with regards to the overall focus, I think this is global, and this is something that we debated quite a bit at the start of the commission, is should we be focused on low and middle income countries, or should we really take a global focus? And the answer was to take this global focus, because we felt that there are lessons to be learned from high income countries for low and middle income countries, but are there lessons from low and middle income countries for high income countries? So that, I know, doesn't answer your question. I think for some of the pieces of research, so some of the reviews are going to be truly global to possibly highlight gaps in our knowledge around certain factors in type 1 diabetes, both globally and in specific contexts. So if we look at the adult and geriatric review that we're going to do, I mean, we haven't completed it yet by any means, but, and don't quote me on this, but I'm sure we'll find very little on low and middle income countries, and I'm probably sure that we're going to be surprised by how little we find in high income countries as well. So I think that's the focus. If we come back to then specific, so the geo-mapping, that's really going to be based on what data is available in terms of mapping out what you need. And again, I'm not an expert in this, is what our colleagues need to map this out is pretty much the geographic location of every single health facility in a country. And so right now, in terms of low and middle income countries, we found a good data set from Ghana and a good data set from Peru. The question is what other countries have that data set available? And then we're also looking at geographic diversity. So if we take Switzerland, where I'm from, tiny country, yes, we have mountains, but we have tunnels, the railways. So it's also to think about what does type 1 diabetes care look like in a very geographic constricted country? So Switzerland, Nicaragua, or Lesotho versus India, China, Pakistan, or other contexts. So again, the idea there is to say no country, unfortunately, has found the ideal situation or ideal context to manage type 1 diabetes. How can we learn from these different pieces of research and the different experiences? And again, as Jessica showed you on the map, the idea is what experience does each individual bring to the table as well? They're not only their professional experience, but where they're from, where they've worked, to feed into this whole process.
Any more questions? Yes, please.
Renza Shibilia from Breakthrough T1D, but I'd like to make a comment in my capacity as a person with 27 years of lived experience with type 1 diabetes. I'm so thrilled to see that mental health is a key focus of this. it is always just so critical that we do consider this, and it's so frequently, as was mentioned, it's so frequently ignored. But my comment would be that even when we are considering mental health in a diabetes context, it's often as a parallel issue. Whereas I know that speaking with so many people with diabetes, the message that we hear is mental health is diabetes care, mental health care is diabetes care is mental health care. So the comment I guess that I'm just making is to look at this in the consideration of a very integrated approach with mental health, diabetes-specific mental health conditions, absolutely, but then also more broadly mental health conditions, with a real focus of how it fits in the lived experience of people with diabetes, rather than it being an add-on, which is often how it is considered. Thanks.
Thank you. Those comments are well taken. Any other questions? Yeah. Okay.
I think, thank you again. Oh, sorry, Ben, I see you're waving.
Yes, it's because we have been monitoring the Zoom live stream all day to see, having questions from the online audience. And it's been a very hectic afternoon. But now we do have a question, and I think we deserve to give that space to the online, if you don't mind. If you can take the question, Anna.
So we have a question online about how early career researchers can contribute to the Commission.
Yeah, very interesting question, and I think the reason why there's a early career research track which is running parallelly, I think to get the inputs, but at the same time, after the meeting, we are meeting them again on Friday morning for the whole half-day session, sitting down with them and actually explaining to them what the Lancet Commission is doing and also getting their input. So they are going to have a full dedicated session for getting their inputs from them. So they are going to be part of the process. Okay, so if there are no questions.
Well, thank you for your input, and I think this is the start of a discussion and dialogue with all of you and to our colleagues online as well. And I think we're very keen to maintain this discussion. And as Kaushik mentioned, during the next 2 days, you've met Jessica, Kaushik, myself. You'll meet our colleagues Karine and Sana very briefly when they've come. If you don't know them already, please feel free to come up to us, add any comments or questions, or be in touch. And then, as Kaushik mentioned, on Friday, our aim is to engage early career researchers in this process as well, and we hope to continue this discussion with all of you. But thank you for your input. And now I'll invite Sana to the podium to lead the panel discussion. But thank you again for all your comments and input.
Thank you. Thank you very much.
Hello, and I know everyone is tired and wants to end the day, but I'll begin with saying this to David, is that not 1,700, but even if we get 17 articles, right, that do not solely rely on HbA1c, that has been my advocacy throughout the Commission, but actually capture the life of people with type 1 diabetes. For me, the Commission would be successful. So thank you so much for all your comments here. We have a very good panel here right now, and we wanted some very organic reflections from these people. So I'll first introduce my panel here and call them on the stage. So I'll first go with Karine. Karine, can you please come up? Karine, for those of you who don't know her, and I'm sure there will be very few, is a pediatric endocrinologist. She's the former president for ISPAD, and she's joining us from Luxembourg. Thank you. Then we have Mats. Mats, can you see? Okay. So Mats is the strategic lead for type 1 diabetes at World Diabetes Foundation and a key player in organizing this meeting. So thank you, Mats, for joining us. Also representing here a funder who's funding the Commission. I'll then ask Stephanie Pearson from Breakthrough T1D. She's the Senior Director for Global Access at Breakthrough T1D. Thank you, Steph, for not only funding this work, but also joining us to share your thoughts here today. I'll then call Molly Lepesca. She is a person living with type 1 diabetes, is an expert in global health communication, advocacy, and campaigning, and she's a project manager for the Access Study. Thank you, Molly. And last but not the least, Nupur Lalwani is the founder of Blue Circle Diabetes Foundation in India. She's an advisor to global access strategy for Breakthrough T1D, and also a Leonard Thompson Award holder and one of my favorite advocates globally. Thank you, Nupur, for joining us. Okay, we'll begin. And I have a question. I have a set of questions, but I have to shorten it a little bit, so I'll join my first two questions to you. And we can maybe go from, we'll begin with Corinne, because she told me she has a paper written up with her train of thoughts that she wants to share. So the first question is, and we'll take turns, is that what are your expectations after you've just listened to what the Commission is planning to achieve? What are your expectations from the Commission, and what would success of the Commission look like to you? So, Corinne.
Is this the one? Yeah. Thank you, Sana, for giving me the floor, and sorry for imposing me a starter. In order to be short enough, because there are so many expectations, not only the 1,700 papers, but I think more something actionable, which really has an impact, and not an impact on the researcher, not an impact on the egos, but an impact on the community and the persons with type 1 diabetes. And so for me, looking back at the future, please not reinvent a wheel which has been invented, but use the wheels which are around to make a really solid car to move forward. And for me, a solid car would look like an answer to what was discussed already before this day. Diamond addressed it. The SHY initiative addressed it. A recent correspondence in Nature addressed it. We need data. We need data if we really want to document what has been achieved. If you want to have a look at the quality of life of a person with diabetes, it's not this HbA1c which is going to give it. It might interact, but if the quality of life is not improving, then I don't think HbA1c makes a lot of difference and is going to be that relevant. So we need data. So I hope that you are convinced that we need that data, but what data do we need, and what data could we fetch in a T1D scorecard, which could be used then afterwards to feed that T1D index? What data do you want? We've got, if you look in literature, the WHO recommendations which countries and governments should collect. Are they going to inform us about how the impact of education, how the impact of a better mental health support works out? It's not going to be enough. We need to have as well the data coming through the registries. And to be very honest, if you look at the different registries which have been created as grassroots initiatives, and that can be by organizations from people living with diabetes, but as well with clinical organizations. And for me, I've been very much involved in the SWEET registry. Wasn't perfect, isn't perfect, but at least we capture what is going on in an ongoing situation. So for me, a T1D scorecard, and if we can move that forward, I think I would consider that a success. If we can combine, say, all the different data which are there, which can capture impact of education. I think education is vital. I think mental health is vital, and I'm certainly not the same. I'm the only one, but quoting a lot of other people. And if we can capture data in that same scorecard, which will as well provide hopefully better data on mortality, because diabetes is not captured very well in mortality death certificates, but that's another point. So then I think we've achieved already one step forward. And I won't read the rest of what I've written.
Thank you, Corinne. Thank you. And thank you for getting this started. And I'll now give the floor to Mads because this panel seems to be gender imbalanced. So please put
Thank you for noticing. To pick up from Corinne, and thank you, Sana, for inviting me to this panel. I think do not reinvent the wheel. It's a good starting point for us as well. I feel there are many wheels out there already. A couple of years ago when WGF stepped up our involvement in type 1 diabetes, one first exercise was to get a full overview of understanding of all the great initiatives that were there. I mean, you mentioned Sweden. We have the Life for a Child program. We have the CDIC program. We saw the child consultation earlier today. There are so many good things happening, both at global level and at country level. But just to get the overview and to get everyone to pull at the same pace in the same direction, I think is my basic expectation to this, is to have some normative guidance globally and some good recommendations that are sort of generally accepted and within the framework, of course, of the Global Diabetes Compact, and then saying, so here are some things to pick up on. And I was very in agreement of some of the comments that were made in the consultation before with Professor Kaushik, in the sense that, as Erica was saying, we want something practical. We are not a lead donor within type 1 diabetes, but WGF supports a lot of programs within the NCD space, broadly speaking, and we really want to find out how type 1 can be integrated into that practically. So we can work with our partners in the countries towards that. And as James was alluding to with the NCDI Poverty Commission, with the PEN Plus, there's so many initiatives that fit into this puzzle. But I think a larger normative approach to how it can all be carried forward, and a roadmap, as you're suggesting.
And maybe a mapping of the stakeholders there. Like, there's so many, and we probably don't know exactly who's doing what and how.
And lastly, I mean, very selfishly, we at the WGF are also using this commission to have a critical look, I think, at our own work and how that fits into it and what we can maybe do better. Because, again, we don't see ourselves as expert in this arena.
Wonderful. That's good to know. So I'll now pass the mic to the community members here. Molly, would you like to take a go on this?
Hi, everyone. I mean, I would say, I think a lot of people say they wear a lot of different hats, but I would look at this sort of with 4 different hats, and I think hopefully, to me, that would be my expectation of what this Lancet committee could do. I think from a public health perspective, I mean, I think I've seen many Lancet commissions come and go at our organization, and I think, you know, the benefit is it can provide some really clear outcomes and clear recommendations for what can be doing moving forward. And that's like sort of at this top level where people within the global health arena might say, oh, okay, these are really important. But I think, you know, and I think if you just look at it from that global health perspective, you can say, okay, this has been successful. But I think, as everyone's mentioned, we need to really go beyond that if we're really going to spend so much time with all of these experts creating something like this. And so then, I mean, from a person who I call myself like an evidence adjacent person, because I work with a lot of researchers, but I'm not myself necessarily a researcher. I think, you know, having something that provides innovative ideas and new approaches, I think is very needed. It feels like, I mean, everyone said already, moving forward, not going backwards. I think type 1 diabetes sometimes feels like, when compared to type 2 diabetes, is sort of in a little bit of a rut, and it would be great to see some really new ideas that could be commonly agreed on in the community going forward. And then for my advocacy communications hat, I mean, I think having some key messages, so thinking about it from the beginning of what our key messages for action are, and having key messages that we can bring to a larger community. I think it's very important. Beyond media is one thing for sure, but also to be able to reach out beyond just type 1 and to have people understand why these steps are important outside of type 1 to really strengthen the health systems in country, I think is great. And then as a person with type 1, I think it could be an interesting way to maybe somehow shake up the community a little bit and provide some new sort of guidance for how the community can come together. I think often we're in a lot of different pillars, as you said, Sana, and so to have some sort of places that we can come together and agree on and push forward sort of in the global advocacy agenda, and then also at the national level, I think would be fantastic. So no big deal, just a few tiny things.
Thank you so much. But one thing that I picked from your, what you were saying is that there needs to be focus on type 1 diabetes, but also integration within the larger diabetes and NCD space. Thank you so much. Well, I'll now go to Stephanie, and Stephanie, as a funder, as well as leader, as well as a key stakeholder in the access work that the Breakthrough T1D is doing, what are your expectations from the Commission?
I think a lot of it has already been said. I think don't reinvent the wheel. I think we've all said that. I think from a funder perspective, give us a plan of action. Don't give us just a report. Give us a way forward. And I think that's the most important thing for us. And give us a way to make data-driven decisions. And that's really why we're invested in this particular commission.
Great, thank you. Nupur.
I think what success would look like this, I want to reflect on what Erica said a while ago about what next, what happens when the commission ends. And I think a lot of it is down to, political leadership. I mean, countries need to make those decisions. Countries need to understand that health is an investment in NCDs, and type 1 diabetes is not a drain on funding. It's an investment in human capital. It's an investment in the economic development of the country. So that's something that success would look like, I think. And I think the other thing is, of course, we've been speaking about this today a lot, about engaging communities meaningfully. Molly spoke about it as well, and not just as something that's nice to have, or, someone that's nice to have in the room, but, tell us what we don't know, because we don't know what we don't know, and we're learning along the way as well. So, we're collaborating with different stakeholders, with academics, with endocrinologists, with researchers, and there's a lot of catching up to do for us as people living with diabetes as well. We have our own perspective, but we have a lot more than just that. And of course, I think right from global experiences, I know I see Bastian in the room with all of that he's done at DDoc, and Sana, everything that you do at Meeti Zindagi, and what we do in India, and everyone elsewhere as well, Mark in Brazil, Tino. I think we have a lot, already going for us. So we have a lot of things that we can share, that colleagues can learn from, and that we can be of a lot of use, to this process and this goal.
Thank you, Nupur. And you highlight a very important question, is that what happens when the Commission report is published and it ends? And I think one of the key messages that the commissioners we want to give is that we don't want this to end here, and we want to make sure that this continues, and it continues into advocacy and policy. A lot remains to be seen about how to actually materialize that, but yes, something that we would be trying. So I'll go to the second question, and that's the interesting question as well, is that what is the key issue that the Commission needs to highlight, and maybe also think about what is the elephant in the room? Whoever wants to go first.
I think I'm stuck a little bit to what I think would be an important outcome, which is data, which can help us to move forward. I think we have the governance of data, the GDPR, which is everywhere discussed, which will be on one hand, absolutely a step forward, but on the other hand, as recently highlighted, is stopping us from moving forward. So we need to see whether we can find solutions in discussion with those who are responsible for that. It was already mentioned this morning, if you collect data, do you do it on an Excel file or do you find an electronic file? How can you reduce the workload within the EU? And then afterwards I stop. We just had a discussion with the EUDF, the Diabetes Forum, that it might be, we really need to look for ways to implement in a not energy time consuming way collection of important information which can tell us as clinicians what direction should we go, as governments what directions should we go, or as persons with lived experience where should I push those who are supporting me those 4 hours and maybe a little bit more sometimes per year in order to get better care and better outcome and the quality of life I just deserve as much as everyone else.
You highlight a very important, this elephant in the room, and to disappoint you further on this part is that things are going to get harder because the community is rallying behind a data rights charter, which from the community perspective is very important, but at the same time, there might be some alignment that the Commission can find, and David, this is, I think, a very important recommendation as to how to actually ensure that data rights are protected, but data at the same time gets collected and used in the proper way. So thank you for this. Who else wants to highlight the?
Yeah, I think I have 2 aspects that I would like to highlight that I think is key. Obviously, the Commission is looking at, as David was saying, globally, but from WDF perspective, our interest lies in the low resource settings. And I think it will be really important within those settings to also be pragmatic or have practical pragmatic recommendations in terms of, and I guess it also relates to data, but to capacity as well, in terms of saying, ideally, we would like there to be a pediatric endocrinologist in all facilities. But if there is maybe one in the whole country of Malawi, then how do you navigate that? So I think some really specific recommendations on these types of challenges, I think, would be extremely useful. And then the second one would be, it was mentioned in the early career research session that I attended earlier today, is we focus a lot on the care part, but what about all the other aspects about it, the social, I mean, touched upon it also here with the mental health, but that could be seen as integrated in the care. But the whole other part of the package, and there are certain aspects in life, for example, when you transition from childhood to adultery and so on, how to navigate that, and I know that there is the life approach is already on the radar, but I think it would be really interesting also for us to challenge ourselves a bit at WDF in terms of we focus a lot on the care. But I think we have to recognize that when it comes to a disease like type 1, it's the full package you need to pay attention to.
Would you like to point out the elephant in the room?
No, you can do so.
Okay. I think the government corruption that was mentioned earlier is probably, for me, the biggest one. So yeah, just doing that on your part. Molly.
Yeah, I agree. I mean, I think the life course approach is really nice. I think it's hard to get any sort of evidence on adults, so I think that's great. But I think, for me, something I think maybe because I'm genuinely curious about it, in particular from an access perspective, is the trying to understand what the challenges and opportunities are between this really growing gap between high-income care and low-income care, and the technology, different elements of care that are now standard in high-income countries and are not possible at the moment in these countries, and how are these people going to be left behind? And I think we often talk about it in the way of like the high-income approach should be the approach, but could there possibly be some other ways? What can we learn from low middle-income countries who are doing things right and doing it in a way that can be sustainable in a place where, you know, maybe we can't afford this sort of whatever you want to say, like the highest package of care and treatment. And because I think particularly around, you know, insulin and glucose measuring and monitoring and all the technology it uses, really understanding how we can use this affordably and make it so it can be used by more people, but in a sustainable way that it can continue on. And to close that gap between care, I think, is an important element.
Thank you, Molly. And you raise a point which is also sensitive and controversial when it comes to, you know, the care gap widening and how do we actually manage that. Stephanie, would you like to comment on this?
Yeah, I think from our organization, we talk a lot about this ladder of care, and we talk about how can we get the countries that we're working with to the top tier of that ladder. And that's really what I'm hoping we can see out of this commission is how do we do that? We know that there's such disparity between those two gaps. How do we get there? And I think this commission, we're hoping to get some insight into that.
Nupur, what's the elephant in the room for you?
We're in the last 5-year cycle of a lot of targets, right? I mean, 2030 is a big year, UHC, SDGs. Are we on track? I mean, clearly not. What are we going to do? And there are so many initiatives. What are we going to do differently in this last leg of, you know, in these 5 years to change outcomes? And, you know, like someone was mentioning earlier, to have a practical, measurable change in what the way things are and to make it better.
All right, great. Anyone from the audience wants to add on to what the elephant in the room is?
So thanks. I'm Mark Baron from the Intersectoral Forum of NCDs in Brazil. I'm sorry for the ones who heard me saying about this elephant previously, but to me, a big elephant is so what we see in the T1D index. So I feel that we need to see a big change in T1D index because, so as the numbers we saw earlier today, I feel and I always repeat, unacceptable that so many kids are dying every day or every week without even being diagnosed with type 1 diabetes, and the reduction of life expectancy is still huge in the entire world, even having all the advances in medicine that we have nowadays. And as we saw, even in high-income countries, even having access, we still see, it was so presented today, a reduction in healthy lives of 24 years. So how is that possible? So what are we doing wrong? How we change those numbers so quickly? How do we work together for this change that is truly needed?
Such an important point. Like if you're, just to reiterate your point, if you're still facing a loss in life expectancy in high-income countries, what are we doing wrong? That's such a big question to ask. And I'll move to my last question now. We're just left with 10 minutes, so please bear with me. So how do you think, and this is to all the panelists once again, how do you think that the Commission can effectively engage the type 1 diabetes community in delivering the work that we're trying to do? Start with Corinne.
If I may quote their words, nothing about us without us, I think how can we as clinicians think, and that's then my perspective, that we can change things if we don't take into account the view of those people living with the conditions who can teach us so much. And wherever I've had the chance to go around in my ISPAT perspective, I've met so many people where I've been silent after having heard how they can convey messages. So I think without them, it wouldn't work.
So let me rephrase my question for the rest of the panelists. We do have around 33% of the community represented on the commission. The 33% of the total commission is composed of community members. But how do you think we can engage them more effectively, apart from being just a part of this research, and along with that, of course?
I mean, I think, number one, I mean, you have to make the Lancet Commission seem like it's, why is the Lancet Commission important? Number one, when, you know, how is this going to change my life in my community with the people that I work with? What is this going to do? And maybe it's, you know, looking at other examples of successful Lancet Commissions and how they maybe changes to policy or changes to practice. I think that's important. But I think also just, you know, relying on leaders, you know, leaders in the type 1 community who are already involved and get, you know, webinars, try and reach people more with these messages and trying to really show how this could be effective in providing advocacy tools, providing, you know, potential ways to push policy, and also maybe showing how it could make a direct impact on, you know, governments and if they are listening to this and why. I mean, even simple statistics like the thing with the Obesity Commission, that it had 1,700 articles. I mean, those things are really useful to people, you know, in the type 1 community, and I'm sure they would take some messages on and try and get to local media. So I think it just has to feel really relevant to people and more, you know, important enough that you would put aside other things for these findings specifically.
I'm struggling a bit to answer this question because I feel to a large extent that doing this is already, I mean, that you don't need my advice necessarily, because I think this is beyond the Lancet Commission. Is of course also the thinking of WDF and co-organizers of this meeting is, again, coming back to it, so important to have a joint discussion about this and to have everybody feel that they're part of a process and of raising what needs to be raised. And that's of course part one, and then part two, maybe like Molly's saying, then is to also see that it's not just counting news articles and it's not just waving a report around. It's being very practical about it and then taking it back. From our perspective, you know, this global consultation is important, but the most important is that we go back to our partners in the countries and say, okay, what does this mean in Kenya or in Ethiopia, and how can we link those two? So I feel that as much as you're the commissioners, I think it's us and everyone else in the room's responsibility to help to implement whatever comes out on the other side.
Right, so involvement in research, advocacy, implementation. Steph, what do you think?
I think that the community is your best resource when you try to implement anything like this. Whether it's advocacy or implementation, I think that involving them from the start is crucial. I think that the commission needs to keep in mind that people with lived experience are not a statistic, they're a person. And so keeping that in mind as they walk through this process and they walk through the data that they're going to receive, and keeping in mind how to make that into something relevant, into something that a person living with type 1 can not only use but advocate for.
Thank you, Stephanie. Nupur, I'm going to add a part of the question to you. As an advocate, do you feel that people coming to the commission as commissioners and later on receiving that report, they might feel overwhelmed? You know, we often feel, specifically when we are in the early career of our advocacy, we often feel overwhelmed being surrounded by researchers, great researchers like David and Kaushik. I mean, you know, it sometimes feels hard. What are your reflections on that process of a community member getting involved in research and then advocacy and then taking it back home for implementation?
Thank you, Sana. That's such a thoughtful question, actually. And I found myself really nodding my head vigorously with every comment that came through in this, last question. I think that building a little bit on what Molly said earlier, I think we need to simplify our advocacy because, we tend to sometimes overcomplicate or, the use of some jargon or language that is not really for the common man, and we're really essentially doing this for the average guy on the street that has T1D. So it might help, and it's probably one of the elephants in the room as well, that a lot of the literature that goes out is complex. An average person wouldn't probably go through half of it. So that's one, and I think I missed saying this earlier, and I want to add this now. I think Steph and Renza would say, I mean, we're not patients, right? We call it the impatient network for a reason. I mean, a lot of us come together as the impatient network. So I think that's something. I mean, we really have to make it simple for people to understand. So maybe, in practical terms, using, like Molly said, webinars or social media to put out what the Commission is doing in easy language.
Thank you, Nupur. Any closing comments before I take one last comment from the audience? Karine, you have a train of thoughts on your paper.
I think, as for my side, I look forward to a lot of interaction with all those here and online in order to make sure that we take the right path and get the information to get this commission work not in a drawer document, but in an actionable program.
Thank you. So we have 3 minutes. Any last comments, reflections from the audience? Okay. So Ben is telling me I can take some more time. Yes. Are there any online as well?
Thank
Maybe
you.
we can take something.
Zoran from North Macedonia. 2 elephants. One that is growing, related to smaller countries like Macedonia, 1.8 million population, and probably also several else in Europe are not interesting for Abbott, are not interesting for Dexcom, is not absolutely as a population. We are not in the list of countries where CGMs can be used. I bought 10 CGMs Dexcom G7 last year, and I cannot download application in North Macedonia. And this is elephant that is growing, because I know people that were saying that, give me, I will crack the system. Not working. I have paid whatever I paid. I cannot use the system. And I think that, I don't know, is somebody in the public coming from this background, but absolutely they must find the way, if somebody is willing to pay, to make it available for us. Because not to talk about how costly they are. I have to give 30% of my monthly average salary in order to be covered by CGM sensors. I'm type 1 for 27 years. Have retinopathy and other complications. This is, I think that, as I said, elephant that is growing. The elephant that we are not seeing, but we are talking about advocacy, is the capacity of associations of people with diabetes. We cannot, at least I'm talking about Macedonia, I'm talking also, I know some of the Balkan countries associations. We cannot talk about the type 1 diabetes or even diabetes community if we have 1% of the population being active or being our constituency. We are claiming 140, 7-8% of the population with diabetes in Macedonia, type 1, type 2. And then when we were gathering signatures before New Year's, asking government to cover CGMs for all population, we gathered 1,400 people. 140,000 is the population, and then 1,400 people signed the petition, and half of it are not diabetics. Come on. Who we are kidding that we are influential, or we would like to be an advocate? You know, if we are ready to get people on the streets and to advocate through protest, that's the way how we can be influential, at least to our corrupted government. It's something that and in that direction, I think that this second one is bigger elephant, because we are talking about something that we will be influential, but actually we are absolutely no constituency behind. I'm talking about my country and probably several.
Well, I think
others.
What you're pointing towards is also true for many larger populations where companies are not interested because the products are not affordable for the general population, so the market size is small. But what you're talking about, the advocacy part, and I think the investment cases would really provide, in my opinion, a good tool for these advocates to actually run through with the government, is the voice behind plus the data there to. And I see your point. I mean, I know that, but I think as a person with type 1 diabetes myself and looking after communities, sometimes it stems from disappointment and lack of hope from the government to do anything. So that's where I think things need to change. Any last remarks? Okay.
Hi, Ileana Gil from Venezuela, representing Guerreros Azules. It's an NGO for kids living with type 1 diabetes. My comment for the Commission was, I'm sure you're going to be including the burden of living with type 1 diabetes, burden and burned out. In the case that diabetes type 1 is very different than other chronic conditions. With diabetes type 1, we think about diabetes every second. We have to, for people who have CGMs, they're continuously looking at it. It's a burden that they live minute by minute, 24/7 we call it. And it's very different than other chronic conditions. Asthma is different, obesity is different, hypertension is different. And I think it could be a measurable tool, like time spent taking care of my diabetes. We've seen time lost in the T1D index. You know, time spent can be maybe used for policies that can be developed in different countries, for schooling, for works, for, I don't know, things like that. I think it would be something useful to include in the Commission.
Well, thank you so much for this input, the scorecard. All right, let's wrap up for the day. And please join me in thanking our great panel here, and also the speakers who have done a wonderful job. And David, thank you for starting this, and we're missing Mark here today, but thank you so much for leading this work. Thank you.